Good afternoon, everyone. It's a great honor to be here again with all of you during the second day of this spectacular basic ICU workshop. I'll be talking today about the protocols and parameters of weaning patients of the mechanical ventilator. So I'll start as usual with the basic key points of this lecture. First, we will define the weaning process of each single individual patient according to the condition and the disease. Then we will define also the terms and abbreviations commonly used in mechanical ventilated patients. Terms on the mechanical ventilator itself, on different parameters, different vendors, because usually we hear a lot of abbreviations. So we need to know what does it mean. What are the parameters for assessing the patient's readiness to be weaned from the mechanical ventilation? We'll talk as well about the modes of weaning and different protocols acquired according to different societies as well. We will speak and we will illustrate which patients are difficult to wean. How long does it take to wean off the sedation, which is a very valid point that sometimes early weaning can lead to the failure of the weaning itself. And last, we will include two last points which are very vital as well: the tips to optimize the weaning and extubation success according to checklist we will provide. Again, at the end, we will also provide different life scenarios for patients who had encountered failed weaning process. So first, we will define the weaning. It is defined as a progressive decline in the amount of ventilatory support that a patient receives from a ventilator. So the weaning process basically includes three parameters, mainly. This process includes first the decreased ventilatory support, assessing the patient's response, and finally, possibly extubating the patient. Well, we know all that eventually the purpose of the weaning process is to liberate patients from the mechanical ventilation. So we'll go to the next key point, which is the terms and abbreviations used mainly in the mechanically ventilated patients. We hear a lot the fraction of inspired oxygen. How can we wean off the patient by reducing it gradually, the FiO2? PEEP, which is a positive index respiratory pressure. Spontaneous breathing trial, the SBT. We will talk a lot about this during this lecture, so remember the abbreviation as well. CPAP, or continuous positive airway pressure, at a part of the weaning and mode of weaning as well. Auto PEEP, or we call it also sometimes intrinsic PEEP, which many of the extensive COPD patients with advanced disease, they have already an intrinsic PEEP related to the dead space for sure. We will talk about this. SIMV mode, the synchronized intermittent mandatory ventilation. PSV, or pressure support ventilation. VT, or tidal volume. VE, or minute volume. The FVT, or the rapid shallow breathing index. This is a very important one. We'll have at least 2 or 3 slides talking about the rapid shallow breathing index. And as well as the PF ratio, we call it sometimes PaO2 or FiO2 or PF ratio as a matter of easier way to pronounce it. This is basically the partial pressure of the oxygen over the FiO2 ratio. We know that usually the normal value is 500 or above. And usually we use it to risk stratify the patients in acute lung injury or ARDS. And finally, I to E, or inspiratory to expiratory ratio. We will move to the weaning modes. First of all, which is very different weaning modes we have, which are basically 3 modes, but we will talk more about the spontaneous breathing mode, or the SBT, the spontaneous breathing trial, which can be performed using the spontaneous mode on mechanical ventilator, or even a T-piece at the end. And this is, we call it spontaneous breathing trial. Second is the SIMV with pressure support. And remember very well that we have to avoid using the SIMV mode as a standalone mode for weaning without pressure support. We will go through this in details later on. Third is the pressure support ventilation, which in some ventilators like the Bennett 840 model is called spontaneous mode with pressure support. In small instance, something called the rapid ventilator discontinuation is a mode of weaning we can use It can be done actually when the patient is perfectly fine, been like less than 72 hours on mechanical ventilation and off sedation since long time, and achieving perfect weaning parameters like the rapid shallow breathing index, less than 105, and other parameters. In this case, you can do spontaneous breathing trial for 30 to 120 minutes and then extubate the patient. Then we will talk about weaning parameters in detail. This is just like headlines for the weaning parameters. It's very simple. Like, for example, the respiratory rate should be less than 25 breaths per minute, which sure we're talking about the spontaneous respiratory rate. Total volume greater than 5 ml per kg. MV or minute ventilation less than 10 liters per minute. And the PF ratio, the one we already talked about, is greater than 200, because when it's less than 300 and then less than 200, that identifies really high risk patient with acute lung injury and eventually ARDS. A very important weaning parameter is the shunt fraction, or we call it the pulmonary shunt fraction. It should be less than 20%. So what is basically the pulmonary shunt fraction in brief? It describes simply the percentage of the blood that reaches the left side of the heart without picking up oxygen, very simply. Like, for example, the patient who has pulmonary edema or pneumonia, for example, they have increased shunt fraction. Excess PEEP, by the way, the positive expiratory end pressure, end expiratory pressure, the increased airway pressures, conditions with severe hypoxia, hypercapnia, all these conditions may contribute as well to an increased pulmonary shunt fraction. So we have to put this in mind. Then these parameters should be fixed first before starting to wean the patient. Usually we calculate the shunt fraction usually by measuring arterial, mixed venous, and capillary oxygen content. Last point, which is very valid, and we use it a lot, is the rapid shallow breathing index, or the RSBI, or the FVT. It should be less than 105. So basically, the patient is likely to be weaned from the mechanical ventilation if the rapid shallow breathing index is less than 105. And sure, this parameter is only available on spontaneous mode of weaning. We will explain it in details in a dedicated 1 or 2 slides later on, after explaining the weaning of the weaning modes and everything, how is to calculate the rapid shallow breathing index, how to postulate it on the mechanical ventilator panel as well. So red alerts, you should really be aware of before starting weaning process. So you know that the weaning process usually may be a little bit of like exhausting or taxing for some patients. So first you have to ensure that the patient doesn't become exhausted or develop signs of respiratory compromise like tachypnea, apprehension, tachycardia, acute severe hypertension, and anxiety. So if at any time this occurs or the patient exhibits signs of respiratory compromise that suggest intolerance to the process of weaning, then you have to discontinue the weaning and place him or her back on the ventilatory support or the previous parameter before you started the weaning process. The fourth point is that before the weaning, assess meticulously the patient the level of sedation, because when the patient is heavily sedated, you have to wait for at least a couple of days till the sedation wore off from the circulation, because some patients, especially with the patients who had liver issues, it takes time. So if there is a residual sedation, this will impede the weaning process and eventually increases the length of time spent receiving the mechanical ventilation. The fifth point, you should always avoid the night shift weaning. I'm sure that all the intensivists are aware of this thing because of many complications occurred during the night or after midnight when the weaning process starts. This is a common mistake, and you don't want surprises late night. And usually the staff are less in the number in night shifts, and the daily rounds that occur during the day will be really more meticulous in assessing the patient's readiness for weaning. And if emergencies occur during the daytime, this will be more manageable in a better way than midnight time regarding the failure of weaning. So the preferred method of weaning, like I mentioned before, is the spontaneous breathing trial. This is basically an attempt to gauge how the patient might do if he or she is immediately removed from the ventilator. And that's why We call it the sink or swim trial. So either the patient thinks or he swims and makes it out of the mechanical ventilation. So the simplest form of it is the TP's trial, where the patient is disconnected from the ventilator and the endotracheal tube or tracheostomy tube is hooked to a flow by oxygen system, usually from the wall oxygen outlet. This transition from the mechanical ventilator tubes to the new tubing attached to the wall oxygen requires really tremendous extra work from the patient. So the patient has to be aware, he has to be awake, and you have to talk to the patient and explain the process exactly. So the key is to withdraw ventilator support while the oxygenation is continued. Same can be done using the CPAP mode while the patient is still connected to the mechanical ventilation. We used to call it long time back electronic weaning. So again, we talked about the pressure support ventilation in brief. Now, it's nice to put this illustration of the mechanical ventilator. This is a Bennett 840 model. And like I said before, the pressure support ventilation weaning mode can be used with either spontaneous or SIMV mode. So in order to understand what happens here, for example, if you use the pressure support ventilation with spontaneous mode, then all breaths are spontaneous and combined with enough pressure support to ensure that each breath generates a reasonable tidal volume, which is a VT. That means that the pressure support lowers the work of breathing for the patient. So it makes him feel better. So it's more comfortable for the patient. So you should start usually the pressure support ventilation at around 5 to 15 centimeter water to augment the tidal volume, like we said, or adequate spontaneous frequency or respiratory rate is achieved. So third step is to decrease the pressure support gradually and reassess parameters and status of the patient. Fourth step, if the patient tolerates the third step, then you have to check the arterial blood gases and vitals, all the other parameters. And if all within normal, then you should consider extubation at that time. Then comes the SIMV. And we have to know, like I said before, that the SIMV mode should be avoided completely as a standalone weaning modality. So usually I prefer to start with a high pressure support ventilation to increase the pressure support for the patient when we start the SIMV mode. So in SIMV, the breath are either a mandatory ventilator controlled breath or a spontaneous breath with or without pressure support. But during the weaning, we have to start with a pressure support. So the original intent of the SIMV was to let the patient's respiratory muscles rest during the mandatory breath and to work during the spontaneous breath. This is the main issue of our explanation for the SIMV and how does it work. In fact, I prefer usually not to start the assisted control or the AC mode for the patient on admission when we intubate and we admit the patient in the beginning. So it has a lot of issues and drawbacks, the assisted control ventilation. But instead I start SIMV, which is considered a weaning mode, but I started from the scratch with high pressure support for sure. So I see it's an initial mode of ventilation as well as a weaning mode. It's not just a weaning mode. And I usually avoid as much as possible muscle relaxants because they have such deleterious effects on the success of weaning later on. And a lot of papers were published a long time back and recently about the use of muscle relaxants in intensive care. However, for some patients, as for example, the severe ARDS patients, you may need to use muscle relaxants eventually during the mechanical ventilation. Here are signs of intolerance or failure during the weaning process. They are all signs, in fact, to portend the failure of weaning if they are present. First is increased work of breathing, like nasal flaring, you know all these signs, use of accessory muscles, apprehension, tachypnea, retractions, then crackles or wheezing on auscultation, oxygen saturation, if it's low, change in the mental status if the patient started to be in somnolence or confused or obtunded, you have to recheck your parameters again. The blood pressure, if the patient is hypertensive, uncontrolled hypertensive, or severely shocked. These are all alerts that can portend the failure of the weaning. Heart rate as well. Cardiac arrhythmia, if the patient had a rapid AFib, SVT, VT, then you have to deal with this first before you start the weaning. The respiratory rate and the tidal volume, in addition to the minute volume as well. These are all signs to portend the failure of weaning if they are present. You cannot start weaning without optimizing sedation and limiting the use of paralytics. So usually we say the less is more. So you should really avoid the unnecessary sedation. Sedation protocols have been used and have been associated a lot with a shorter duration of mechanical ventilation and are currently recommended by international guidelines. Number 2 tip is diaphragm protective ventilation to prevent the respiratory muscle complications of mechanical ventilation. So prolonged controlled mode ventilation is associated usually with numerous complications, including respiratory muscle fatigue, dysfunction, atrophy, and with poor outcome as well. High tidal volumes, excessive inspiratory efforts are associated with both lung and diaphragm injuries. The effort-dependent lung injury has been termed patient self-inflicted injury, or PSILI. Third tip is the daily screen of spontaneous breathing trial. So it's a rule, no inotropes or cardiac support should be on the way or ongoing during the weaning process. The PF ratio should be more than 150. You cannot start weaning a patient if the PF ratio is lower than that, because that really signifies for and portending, like expecting a very poor weaning process and eventually failure, because it's associated with significant lung loss and ARDS if the PF ratio is less than 150. Sometimes even we prefer that the PF ratio is more than 200 in order to start the weaning process. Then the FI2, it should be less than 40%. You cannot start weaning a patient when he's like high FI2 requirements, like 60 or 70%, and the PEEP is high, more than 10 centimeter water, for example. You have to minimize all these parameters before you start the weaning process. Tip number 5, choosing the best spontaneous breathing trial at the bedside is usually not an easy task. So can I really wean and extubate my patient with a low risk of reintubation based on this spontaneous breathing trial? It's not easy, like we said. And you should really avoid the easy spontaneous breathing trial. So what is the easy spontaneous breathing trial? It is characterized usually by high assistance, example like high pressure support, around 7 centimeter water with PEEP, 5 centimeter water or more than that, and short duration, like 30 minutes. This usually, we call it the easy trial because there's a high assistance to the patient. So you cannot take an action after that easy trial because it's associated with higher risk of post-extubation respiratory failure. So this is the reason why most recent guidelines suggest that the spontaneous breathing trial may be performed if it has a low level of assistance, not a high assistance level, like I showed in the slide here. So, and it should be a short duration, around 30 minutes, not more. So the pressure support should be around 5 centimeter water, not 7 centimeter water when you start the easy spontaneous breathing trial. The PEEP should be 0 and not 7 centimeter water when you start the process. And the breathing trial or the spontaneous breathing trial should be around also 30 minutes. It shouldn't be prolonged because that's more fatigue for the patient. Like we said, it will portend, if you follow the easy spontaneous breathing trial, a post-extubation respiratory failure rate eventually. Tip number 5, follow a protocolized weaning strategy. It means daily and systemic use of a checklist. We will get to the checklist in the next slides. Tip number 6, quickly intervene when a spontaneous breathing trial fails, because you may unmask actually other several undiagnosed conditions with positive pressure that should be addressed and treated before the next trial. Tip number 7, difficult to wean patients make up actually around 20% of the mechanically ventilated critically ill population. This is a high rate, 20%. So the risk factors are being, as I show here, elderly patient, if they have cardiopulmonary comorbidities, the female sex, being affected by cardiopulmonary comorbidities and the duration of the ventilation, usually more than 7 days, if there are copious secretions and improper or inadequate chest physiotherapy and spirometry. So that was regarding the difficult to wean patient. So tip number 8, do you know that 10 to 5% of the patients will need to be reintubated within 48 to 72 hours post-extubation? That's really a large number, 10 to 15%. This is why post-extubation respiratory support is really vital. So use the standard oxygen therapy in easy to wean patients. This should be used basically in patients who doesn't have extubation failure risk factors, like we mentioned before. On the other hand, in high-risk patients, the combination of high-dose non-invasive ventilation, at least 12 hours per day for 40 hours per extubation with high-flow nasal oxygen, is associated with less reintubation rate if we compared it with high-flow nasal oxygen alone. And the last tip, the tracheostomy. Some patients we have to consider late tracheostomy, more than 10 days of mechanical ventilation. And you know the guidelines that usually you should consider tracheostomy after 7 days of mechanical ventilation. But there are some eligible patients we should consider for late tracheostomy. Those who may, for example, benefit from gradual weaning and constant airway mucus plugging control. Patients deemed to be extubated soon for reversible cause, like, for example, recovered cardiogenic shock with normal other parameters, or unwillingness of the patient or the relatives, or the patient or the relatives wish themselves. We will get now to the weaning assessment. Here is the checklist of weaning assessment. We talked about these parameters before, but you know that the weaning readiness is determined by assessment of the patient's stability, resolution of the reason for mechanical ventilation, and achievement of selected weaning criteria goal. For example, in this box number 1, you can see here that basically we will have 3 boxes. This is the first one. It describes the standard weaning criteria, like negative inspiratory pressure shall be less than -20 to -30 centimeter of water, spontaneous tidal volume more than 5 ml per kg, vital capacity is quite good enough. FiO2 should be less than 40 to 50%. Sorry. The minute ventilation should be less than 10 liters per minute, and the PEEP should be less than 5 to 8 centimeter water. Then we'll get to the box 2, and I've already told you in advance that we need to talk more about the rapid shallow breathing index. So this describes the RSBI, or the FV tidal volume, the frequency over the tidal volume of the patient. This is basically done only in the spontaneous breathing effort, not on the other modes. So how can we calculate it? We said before that this ratio should be less than 105 to portend a weaning success. If it's more than 105, and some studies say that in the elderly, it's accepted to be till 130. So if it's exceed that level, that it portends really weaning failure. Let's suppose that respiratory rate is 40 breaths per minute, and the tidal volume achieved by the patient is 200 ml, which is low. So we will use the liters, not the milliliters. So we will say 0.2 liters. This is the tidal volume of the patient. So if you do the math and you divide the frequency over the tidal volume, the rapid shallow breathing index will be 200, which is very high, and that portends failure of the weaning. So it's a simple math. Usually most ventilators, which are the new ventilators, you can get this math automatically calculated. You don't have to do the math at all. There's the screen where you get the parameter, the curves, everything, and you will get the RBSI, or the frequency over the tidal volume, automatic. So you don't have to calculate it. So we have as well to be attentive to other clinical factors during the weaning assessment before initiating the weaning trials. Most predictors focus usually on the pulmonary specific factors, but there's a lot of other factors as well. For the clinical tools, there's something called Burns Weaning Assessment Program. This is actually box number 3. So it ensures systemic attention to these factors, and it may help ensure as well the good outcomes if you follow this checklist. It's a very large checklist. We don't have to go every single point separately. That will take much time, but just put it in mind to revise it later. It's a nice checklist to keep it in the ICU for the weaning assessment before you go for the weaning final decision. So like I said, it's a long checklist. You can see that it includes vitals, it includes hemodynamics, it includes hematocrit value, hydration of the patient, nourishment, albumin level, electrolytes, if there's hyper or hypokalemia or hypocalcemia, any electrolyte derangement, if the patient had adequate sleep or he has insomnia, because that portends also failure of the weaning, the appropriate level of anxiety, absence of any bowel problems like constipation or diarrhea, breathing pattern, residual chest infection, pain control. It's many things. Just keep a copy of it. It's nice to help. And by the time you will get trained to it, you will just manage to finish it very fast before you really get a glimpse or a good idea of this patient will be weanable or not. This is a continuum of the box 3. You can see that it includes even parameters on strength, endurance of the ventilation, in addition to EBG analysis of the patient. So finally, the score is calculating. This score, I mean, you have to divide the number of yes ahead of this 26 points by 26. So when you divide the number of yes by 26, whenever score is higher, it favors increased weaning success rate. If the score is low, like for example 5 or 6, that portends weaning failure. More of the weaning parameters we talked about already. We already had been through this. So we talked about the PF ratio, which we managed to abbreviate it better in that term, PF ratio instead of PaO2 over FiO2 ratio. I'm sure you're all aware of its significance and its correlation with the mortality rates in the ARDS patient. You can tell here that the mortality increases further much, around 45%, when the ARDS is severe and the PF ratio is less than 100. When it's over 200 or 300, that portends a lower level of acute lung injury, and the mortality rate is lower, but still high for sure. So you have to be careful, because you cannot use this PF ratio when the PaCO2 or the partial pressure of carbon dioxide is high, or there is suspected a high pulmonary shunt, since it will not really reflect the correct values. So avoid this 2 parameters to calculate the PF ratio if you have the shunt, if it's high, and if the PaCO2 is high. There are 2 slides which portends as well difficulty in weaning process, like the drive to breathe, the central drive. If, for example, patient's still on sedatives and it's not yet wearing off the circulation and he's drowsy, that portends difficult weaning. This is regarding the central drive. If the patient is COPD and he has a loss of hypoxic drive, if there's metabolic alkalosis due to hypokalemia, for example, neuromuscular disorders like Guillain-Barré syndrome, myasthenia gravis, critical care myopathy, electrolyte derangements, this all portends difficult weaning or weaning failure, as well as the increased resistance of respiratory tract like bronchospasm, residual infection, thick secretions, severe pneumonia, unrecovered pulmonary edema, patient who has very high intrinsic PEEP or auto PEEP, large pleural effusion, which we will get through in the live cases, and how this can portend the weaning failure. So these are the last part of the lecture. It's basically live cases with failed weaning. For example, you can see this patient. It's a demo for a patient who has severe loss of aeration. There's a lot of coalescent B lines reflected from the pleural line, and they are multiple all over the lung field. They are regularly spaced with a limited portion of sector. So this basically portends weaning failure, because you can see that patients still have interstitial pulmonary edema or cardiogenic pulmonary edema. So you cannot do an ultrasound on the lung for this patient during mechanical ventilation and suggest or take a decision immediately that you should wean this patient. You have to manage first treating the pulmonary edema. So this is very interesting. We had this slide as well yesterday during the lung ultrasound lecture. I'm repeating it here because that patient actually, he has a total lung loss, as you can see, with significant lung consolidation. This patient had a COVID-19 pneumonia. You can see that the lung is completely destroyed. This finger-like projections in the lung tissue. And this patient is mechanically ventilated. He has a large, free-flowing pleural effusion with extensive hypoechogenic areas. So we really wean this patient of the mechanical ventilation, or we still have to wait? Sure, this patient cannot be weaned yet. This is a huge amount of pleural effusion. By the way, for illustration only, this is the liver, this is the diaphragmatic edge, this is the lung itself with atelectasis, severe lung loss, this is the effusion, and this area over here, this glistening, brightening bar, this is actually the vertebral column, the spine. When you have pleural effusion and you scan the patient, you can really see the thoracic spine on the back. So this is a reflection of it. Again, you can appreciate here that there are cracked and irregular pleural line with frequent B lines on both lungs. This is a patient with severe pneumonia. I believe whoever attended yesterday's lecture also can appreciate how this patient is in severe pneumonia, and there's significant lung tissue damage from the lung ultrasound. Like we said, cracked, irregular pleural line, and frequent B lines reflected through the whole lung field. That's a patient with a massive right lung collapse, as you can see through the chest X-ray. There's a huge amount of pleural effusion. So it should be drained first. You cannot also wean this patient because it will probably 100% a failed weaning trial. That patient had a past history of mechanical valve prosthesis, as you can see here. So drainage is a priority before the weaning trial. So this is a very important slide. And this is an example of how weaning can fail in patients with cardiogenic or septic shock. So as you can see from this curve, that the mortality rate increases dramatically when vasopressor requirements increase as well. So you can see from the curve that if norepinephrine dose is more than 0.3 over here, if it's more than 0.3 mic per kg per minute, actually the in-hospital mortality approaches almost 40%. And if very high rate of infusion, more than 1 mic per kg per minute, the mortality rate even increases up to 80 or 85%. So being on high dose of vasopressors predicts a failed weaning process. You have to remember this very well. And at this point, you cannot really think of starting the weaning process of mechanical ventilator unless you wean the patient first of the vasopressors. This is very interesting as well. This is a live patient as well, and that patient is on mechanical ventilation. You can see that from the echo, a short axis, an LV short axis view, that there is severe LV dysfunction, and the patient is having already a mechanical complication on the other side. This is a severe grade 4 mitral regurg, which likely due to ruptured chordae tendineae. That patient for sure will fail the weaning if started prematurely before stabilizing the cardiac status. That means he has to be on the inotropes. Cardiac function should be stabilized first before we start the weaning process. Another patient is the patient who had cardiac arrhythmia. You should also avoid the weaning in the setting of cardiac arrhythmia. Either it is a tachy or a bradyarrhythmia. First, control the insistent arrhythmia by treating the cause, and then you should start the weaning process. So all the previous causes can be reasons for failure of weaning. And these are possible clinical criteria related to spontaneous breathing trial failure specifically, like when the PO2 less than 60 millimeter mercury, or FiO2 is more than 50% during the SBT failure, the SBT trial. Saturation less than 90% on higher FiO2, more than 50%. When the CO2 is more than 50 millimeter mercury, when the pH is less than 7.3, or the patient is quite acidotic, that portends also a failure of spontaneous breathing trial. When you have a frequency over the tidal volume, or we talked about it, the rapid shallow breathing index, more than 100 or 105, that portend also failure of the weaning. When the respiratory rate is more than 35 breaths per minute, when the heart rate is very high or still very low as well, like patient who had heart block, when the patient is uncontrolled hypertensive patient and you cannot still control it, you cannot start weaning, or the patient is shocked, still you cannot start the weaning process. So these are all possible clinical criteria related to the spontaneous breathing trial failure. Finally, here is a simple algorithm for discontinuation of mechanical ventilation. So you should revise first the reason for the ventilation, if it's improved or resolved or not. You should do daily screening of respiratory function, like the PF ratio, PEEP, if there's adequate cough reflex, the rapid shallow breathing index during this continuous trial, is it lower than 100 or higher than 100? And no vasopressors or sedatives. If yes, then you should go to the next step, which is the spontaneous breathing trial. Like we said, we should make it short, 30 minutes, not more. You can do it with the T-piece, you can do it with the CPAP, like the electronic weaning, or low-level pressure support. So if the patient here is poorly tolerated, then you have to do gradual weaning, daily T-piece trials, or pressure support ventilation. However, if the patient is well tolerated, then you can go for extubation. And from the beginning, if you found that the patient is still not achieving this parameter, then you have to continue ventilation and postpone the spontaneous breathing trial. So after extubation, there's a lot of factors we mentioned about the respiratory failure post-extubation. So if the patient has failure of weaning, consider trial of non-invasive before you re-intubate, because usually the re-intubation portends also poor prognosis. So you should try first CPAP or non-invasive ventilation for around 2 hours if the patient has cardiogenic edema or COPD. However, if not responding, then you should intubate immediately if appropriate. Finally, the comments and the take-home message. So all patients receiving ventilator support should be assessed daily for their suitability of weaning. This may involve meeting several preconditions and then spontaneous breathing trial. If unsuccessful, weaning should be attempted using either pressure support ventilation or daily spontaneous breathing trial of increasing duration. Third comment is a tracheostomy. We talked about this, that it could be helpful in patients who are difficult to wean. However, you can postpone it more than 10 days in specific patients like we talked before about. It's good to mention as well that over 95% of the patients should be weanable in this way. A few patients per year may need referral to a long-term weaning unit. Thank you very much for your attention. I do really appreciate your time. Thank you.